So we're going to be talking about the Behavioral Health High Utilizer Matrix. This is a data collaboration between public health, law enforcement, EMS fire, as well as our jail services. So for our learning objectives for this session, we wanted to focus on identifying community data that you guys would have available in your jurisdictions, describe the process and the buy-in that was involved, and then how do you leverage these collaborations to actually have outcomes versus output, so to speak. So a little bit about Peoria. I think many of you know where Peoria County is, and I'm saying that just because I think we are really important, but just in case, not so much. Peoria is located in central Illinois. We have a population of approximately 186,000. It is decreasing since our 2010 census. A lot of people are moving not only out of Peoria, but also out of the state of Illinois. Our population is also aging, so we have really far ends of a very old population and then very young, and then our middle grouping is leaving the area. Very common in central Illinois. I see Don Cavey of Logan County saying, yes, that's very similar. Our county seat is the city of Peoria. It actually accounts for 61% of our population. It is our urban center. So we have an urban center of the city of Peoria, and then everything else is really rural. Our demographics are a little bit unique in the area because we do have variety, so to speak. 62% of our population is white, 27% is Black African American, and then 4% is Asian. Of the 27% that are Black or African American, over 90% live in our city of Peoria. So our minority base lives primarily within our urban center. Peoria is famously known for used to being the headquarters for Caterpillar, as well as the nomenclature, will it play in Peoria? If it plays in Peoria, it plays anywhere else in the United States, and we still do see that aspect involved. So the bio that was mentioned, Peoria really started discussing how we can improve our health by realizing that we can't do it alone. The Peoria City County Health Department established in 2014 a Community Health Policy and Planning Division. The primary focus of this division was really understanding how, as an external community outside of our mandated programs, we were really moving that dial, taking our I-Plan, Community Health Needs Assessment, Improvement Plan, and really putting it into action. So one of the exciting aspects of my role is that I have fantastic staff. And that individual is Melissa Adamson. She actually did a crosswalk with all of our community agencies in our neighboring counties and came up with the realization that we all had the same needs that we were trying to change. When this was done, our last session, obesity was around the board, mental health was a majority of them, reproductive health. I mean, it pulled the gamut. And yet we were doing it all in our own silos because we like to do that work. So with that, we took the next cycle of our improvement plan as well as our hospital systems required ACA requirements for their improvement plan and decided we were going to do one singular needs assessment. And that's really where the Partnership for a Healthy Community came forward. It's a tri-county collaborative centralized around one needs assessment, one improvement plan. The four priorities that came in our 2016 plan was behavioral health, which was mental health and substance abuse, healthy eating, active living, cancer, primarily breast cancer and lung cancer, and then reproductive health. Reproductive health is a primary Peoria County issue. We're number one in gonorrhea in the state of Illinois, number 3 in chlamydia, and our teen birth rates are anywhere between 3 to 5 times the national and state values. In addition, we have high pockets of preterm births. So as a county as a whole, we're roughly around the Healthy People 2020, 8%, but we do in our urban centers go anywhere up to 13% of our births are preterm births. So reproductive health was a primary Peoria County issue. Cancer was actually a primary issue for Woodford and Tazewell counties. If you were to go to the EMA website, you can actually see where pockets of radon are in our community, and Tazewell County is actually one of the highest radon areas in our state. And so lung cancer, and specifically the relationship with radon, was one of the health priorities for our cancer group. Healthy eating, active living, this is going to be always across the board, and I think today's discussion was spot on. Obesity is still an epidemic, and this was one that was challenged across our entire community. Our data shows something that we all also recognize, which is we were very good at being active living All of us are horrible at eating healthy, apparently, and so that was one of our core priorities. And then lastly was behavioral health. And in our community, our data really spoke about issues that we saw. We saw Woodford County over a single year triple their number of suicides. We saw the increase of opioid uses from 2016 to 2017. Peoria County alone, 83% was our increase. Majority was of overdose deaths. Majority was related to fentanyl. Very common picture in Central Illinois as well. And so we chose to focus on two areas, really mental health and substance abuse, with 4 measurable objectives. We wanted to improve the number of good mental health days. We wanted to decrease the rate of suicide, decrease the rate of substance abuse, and let me make sure I phrase this correctly, decrease youth's positive perspective on marijuana. So we realized that from the Illinois Youth Survey, within one cycle, the number of seniors in our community realized marijuana wasn't that bad. What changed? Legalization laws. As soon as it changed, we started seeing that it was not as bad. In terms of even actually drinking under the influence, marijuana use was safer than alcohol. And so we realized we had to address some of those perceptions as well. Interestingly enough, we actually kept suicide and overdose deaths together. This is best practice when you're looking at behavioral health and substance abuse, because the differentiation between a suicide and an overdose is the coroner's decision. The coroner makes the call, depending on what information they see at the scene. And so really those two data points go hand in hand. So if you're really looking at just opioids and wanting to look at your overdose death, you should also be looking at your suicide rates at the same time, because it really is dependent on your coroners. And in Illinois, our coroners are elected officials. So another aspect. In some states, they are trained, they have to have a medical background, they have to have a lot of special training courses and so forth. In Illinois, because of that, very important to look at both of those data points. So these, again, is our goal and our 2 main goals and the 4 items that we wanted to change, the 4 measurable data points that we wanted to see improvements on. So when we looked as a tri-county, our biggest takeaway was it had to be evidence-based. If it was not evidence-based, we weren't going to do it. No matter how nice it felt and how good it felt, and in public health, we're very familiar with doing programs that feel good, but don't do anything. Health fairs are fantastic. I love meeting people, but we don't necessarily change anyone from the population standpoint. So we had to do evidence-based. Our strategies actually focused on 3 pockets as we moved forward. It was focused on healthcare, criminal justice, and school districts or education. Healthcare, I think the presentation right after us is going to go into much more detail, but for healthcare, we wanted to look at primary health, behavioral health, primary care integration, so making sure the dialogue on behavioral health was in the same conversation as high blood pressure as well as diabetes. It's just all-encompassing. Culturally adaptive healthcare. This is a very personal thing for me to talk about, which is when I think about behavioral health as my background as a child of immigrants, it was not behavioral health, mental health. It was, how you're feeling. I know peers that think of it as more of they're going through episodes or their spirituality. So understand that when we're talking about healthcare, language matters. And so how do we address it so that it is welcoming to all? And then mental health benefits legislation in terms of reimbursements and even what we can do to promote getting skilled workforce into the state of Illinois, because that was a depletion point. So that was really the focus on the healthcare standpoint. On the school education standpoint, ESSA, which is the new kind of No Child Left Behind, but every child succeeds or every student succeeds, social emotional learning is now going to be a part of a measurement for them, much like reading and arithmetic. And so with that, how do we integrate ESSA, from ESSA's requirements, how do we integrate social emotional learning into our schools and what support they need? We have, in this tri-county, we have Peoria Public Schools, which the best way to describe it, it is a beast. It is 3 high schools, a plethora of middle schools and elementary schools. And in terms of ACEs or adverse childhood experiences, those kids have seen it all. On the other spectrum, you have Dunlap, which is a high social and economic neighborhood. Again, their ACEs are possibly a little bit different than you would see maybe in terms of level of violence, so to speak, but there's a totally different realm there. And then you have schools like school district like Fieldcrest. Fieldcrest is, I think in the state of Illinois, it is the largest school district by area. So it covers actually 3 counties. The high school is in 1 county, and elementary school is in a second, and the middle school is in a third. And they actually saw in their spring, they saw 3 attempted suicides. In the past 10 years, they've only seen 1. So again, we're seeing the full gamut. And so when we talked about social and emotional learning, it had to be fulfilling all the needs of all these players. And then, of course, with everyone else, we also had the aspects of our opioid and substance abuse reduction, targeted trauma interventions, and then the justice system level. So while there were 3 different kind of areas, by no means did it mean that we did not talk to each other. In fact, we all recognized that we spoke to each other. And I'll share a story about this a little bit later on as we go through these slides. So when we talked about how we were going to organize ourselves to really, as a tri-county, move this forward, we had the Partnership for a Healthy Community. It is structured as a board. We have representation from all different sectors. Each of the 4 priority areas have their own committee. And then for us as behavioral health, we actually have 3 areas: education, healthcare, and criminal justice. And under criminal justice, we did not want to reinvent what we already had in our community. And that's where the criminal justice behavioral health intersect came into play.
Okay. So, the timing of the development of the Community Health Improvement Plan and the recognition of the seriousness of behavioral health issues in our community coincided with a serious issue in the city of Peoria around homelessness. One of our shelters was closing, so people were seeing the homeless more. This was the summer of 2016. We were starting to get an uptick in our opioid overdoses, and we could see from all of our data assessments that behavioral health was an issue. So we launched our own version of the Data-Driven Health and Justice Initiative. We weren't a grant recipient, but there are enough toolkits out there that we felt we could start our own. And this common theme is how we were able to bring everyone together. Whether you were from the homeless perspective, you worked at the hospital, you were a first responder, or you worked at our county jail, you saw the same issue over and over of people cycling through the system, our high-need folks. So low-level criminal offense, possibly a homeless person trespassing, the business owner calls 911, it's some sort of erratic behavior, the officers see that as a need for an evaluation, so they're taken to the emergency department, usually Unity Point, which is the hospital that has our psych unit. The hospital would kick them back out, say either they would get a mental health evaluation or you're wrong, police, this isn't an emergency intervention situation, they just need to be arrested. So then they get sent to jail. They could have their initial hearing, bond hearing, and they're released on personal recognizance or given a notice to appear. Then what would happen is they're trespassing again. Maybe we're moving into the winter, so they're starting to trespass to sleep. The police are contacted. Not only were they trespassing, but now they have a failure to appear on their record. So this ups the bond situation. Maybe they can't pay their fine, so they're in jail a little bit longer, but that might be okay because they're getting 3 squares a day. But again, ultimately they are released because of population density. And again, a little bit later, they're found trespassing. Maybe this time they're taken to the hospital again. They're seriously impaired with drugs or alcohol. Hospital kicks them out. They're sent to jail. The cycle goes on and on and on. So with that common theme, everyone was frustrated with each other. They all were pointing fingers at the people either up or downstream from them as to why their system was being overburdened. The police were fed up with responding to the same people for the same calls. They felt that the hospitals or our behavioral health providers should be doing a better job at treating these individuals. The hospitals' waiting rooms were overflowing. They were tired of giving several mental health evaluations to the same people. The jail feels like these people should not be there. They should have been diverted before they came into their system. The health department is saying, guys, this is the data, we can help, but they didn't necessarily have a place at the table before the health improvement plan made us realize that there are chief health strategists. And the homeless service providers are at their wits' end. A lot of these individuals who are cycling through are on the no trespass list for the shelters, but the police continue to bring them to the shelter because they don't want to arrest them, they don't want to take them to the hospital, but they can't leave them on the street if they've been called. And the homeless service providers, they don't have beds, they aren't equipped with handling the outbursts or the issues that these people have, so they're rejecting them. And basically, we all came to the table. Oh, really important in our community is we have really strong problem-solving courts, which is a name for drug court, DUI court, mental health court, and veterans court. Our Judge Lisa Wilson, is fantastic, and so she's been a huge part in bringing these services to our community, but two issues arise. Number one, the state's attorney is the gatekeeper for some of those courts, so if our court officials don't understand underlying causes, social determinants of health, they might not admit these people. Public defenders might not know these resources are available, or the restrictions or eligibility for these courts is so high that the people aren't offending seriously enough to get into this program. So they're in that weird middle place where there's nothing available to them but to cycle through. And our probation court services started a pretrial program in the fall of 2016, which has helped provide that intervening space when we identified that was a gap. So the health improvement plan basically gave us grounds to bring all of these people together, and we followed the sequential intercept model, which is an evidence-based strategy that's used across the country in these types of initiatives. And we brought together the providers, first responders, community services of each intercept, as well as the corresponding medical provider at each intercept. So I'll kind of walk through our players here. We also adopt the model that includes an intercept zero, which is the community before first contact with law enforcement. So we have a very strong continuum of care that's run through our Heart of Illinois United Way, and that came under the umbrella of the United Way, I want to say maybe in 2015, 2016. So that was it was beneficial to us that they had sort of convened and launched the HMIS system before we got together, because then we didn't have to herd all the homeless providers. They already had a strong group. Within that, specifically, we work with our Southside Office of Concern, which is one of the housing providers. They're also the recipient of homeless outreach grants. So we have them in addition to the representative from the Heart of Illinois United Way. We are blessed with a plethora of resources in Peoria across the board. That's never really been our issue. Our issue is coordinating that service and avoiding duplication. So we have Advanced Medical Transport, which is a private nonprofit first responder agency. We have Fire EMS, and we have a behavioral health crisis response, a behavioral health organization that does crisis response as well as has a crisis center with detox beds. So that's our Human Service Center partners. Then again, with the plethora of services, we have two large health systems. One is OSF, which is our Level 1 Trauma Center, and the other is Unity Point, which again is more known for its behavioral health services. And again, I included Human Service Center a little later on as well, because they are the medical partner at the jail, and they are the medical treatment partner for mental health and drug court in the court services. Then down below, we have sort of the more anchor institutions, if you will, of the Peoria Police Department, where I work, the Peoria County in general, but we have the Peoria County Sheriff's Office with both patrol, street officer, and jail representation. We have court services in the state's attorney's office and judges from that system. And again, the Southside Office of Concern is highlighted again at the end because they are key players in preventing recidivism for the homeless population through their homeless outreach services. So when we first got together, this is our timeline. We launched the group after the planning process from about May through the end of summer of 2016. And then we had our first Criminal Justice Behavioral Health System Review meeting. It's a very creative title. It says what it is. In August. And we just began sort of a self-assessment at each intercept point. We had every agency describe their process, how an individual with a behavioral health need moved through the process. So we were able to identify our strengths and our weaknesses and developed a strategic plan based on that sort of gaps analysis. Then a few months passed, and in early 2017, we heard that the Community Care Planning Committee relaunched itself. So this was a group primarily of medical providers, healthcare providers, who had been meeting prior to 2016, but then stopped, A, because of information sharing barriers. They couldn't agree on a consent form, but also they knew that the community health improvement planning process was underway, and they kind of figured they could fall under that umbrella. So when they relaunched in early 2017, we, of course, brought them to us, and they became an informal subcommittee of the Criminal Justice Behavioral Health System Review. Their purpose was to identify the frequent flyers or high utilizers at the hospitals, and within the hospital system, come up with a care plan of treatment providers. What we did when we brought them into our group is added those external partners. So we brought in AMT, who has an outreach grant from one of the hospitals. AMT has, Fire EMS also has a desire to do outreach for the people that call them frequently, and we had the homeless outreach services. So we added these sort of external people to the community care plan so that all the time they're spending not in the hospital, all those other people understand what the care plan is and can sort of divert them from their knee-jerk reaction of walking into the hospital or calling the ambulance. So once we did that, that group is who launched the initiative of creating our high utilizer matrix, which is what we're here to talk about today. So not only did we want to know the high utilizers in the emergency departments, but we also needed to know the high utilizers of all those external partners. So we began to beta test this process, and of course we ran into hurdles of who can see what, who's comfortable with releasing what. Surprisingly, AMT, oh my goodness, we need to move faster. Basically, the moral of the story is everyone was very open and willing to share, and the health department played a critical role in sort of being a data convener. And what we're experiencing right now is we have everyone's data but the emergency departments, and we've come up with a strategy to overcome that hurdle. So we have run the preliminary with our 5 stakeholders, and the plan from this data is to send the list with names and date of birth to both of our representatives from the emergency departments, and they will send back to us aggregate data on, of the people that we send them, how many emergency departments visits have they had and how much did that cost. So Monica will talk a little bit about the details of our matrix so far.
So I think a key takeaway from our matrix was the fact that there are legal requirements at every point of data. And so just a general understanding, your medical data is right here, behavioral data is right here in terms of hierarchy of confidentiality, and then substance abuse is way up here. So it's very protective. And so when we beta tested, one of the first things we realized is the jail has a lot of data, and it's public information. I mean, you can go in and look at the booking reports on a daily basis, and people do that apparently. But one of the things that we found out is they used to flag individuals with behavioral health, and so we thought we'll start with that. Of course, when you flag someone with behavioral health, you're providing health information. So after the beta test, we learned that and decided we don't want your behavioral health flags. We just want your frequent flyers. So in a 2-year span, who comes to you 6 times or more? And when we actually had them compare it themselves internally, it was a 98% match. Their frequent flyers, 98% of the time, had a behavioral health flag. So we didn't have to ask for behavioral health data, we just had to ask for random, hey, what's your frequent flyer information? Human Service Center also offered information, AMT and our fire department. And for us, our fire department is really interesting. 80% of their calls are EMS calls. So for a fire, only about 20% of the time they go out for actually a fire call, so to speak. So if each individual agency just looked at their own frequent flyers by their definitions, you'll see that Peoria County Jail had 250, Human Service had 29, AMT had 22, Peoria EMS had 11, so a total of 315 high utilizers. That's a lot of work. When you actually cross-reference it, it goes down to 17. We had 17 people that were using multiple points of time repeatedly. So for example, somebody could have been at the jail 8 times and then been at Human Service Center 6 times. Or 25 times they called EMS AMT and 39 times Human Service Center. We have this person here who is jailed 6 times, 23 times at AMT, 10 times at Human. You can get the picture. So these are just top 5 that we picked. So there were 17 that actually crossed more than one venue. And when we actually decided how to leverage this, because we all knew the story, we've heard it enough times with the pointing, everyone knew. In fact, our first person that we tried to beta test for the care coordination plan, everybody said, oh yeah, I know him. I get that story. So then we actually decided to put in numbers, real numbers to make matter. So Peoria County Jail for a 5-day average booking, knowing their cost per day as well as the staff time, they roughly estimated $2,000 per average booking. Fire and AMT gave us about $400 for transport. Not treatment, just transport. And then Human Service Center with their skilled workers and everything, $25. These are all very low values. But just with our top 5 individuals we had, giving this matrix $250,000. That was how much money is spent on 5 individuals. And so that's where the leverage happens. No one has $250,000 to leverage, and how do we make the most bang for the buck? So this was really our next point in time of understanding $250,000, that's 2 full-time people, 2 highly skilled full-time people to do care coordination. This is where the investment back comes into place. So we do have an evaluation plan. The idea was that we'd look at our list every 6 months and then understand where the individual change and what then the high utilizer may enter or exit our system at any given point in time. And so our goal is to really keep evaluating this to see where people are moving in and out of our system, so to speak. Our next step, too, is because we're located right on the river, is that to group in our neighboring counties, especially Tazewell County. Because if you're not in Peoria jail, there's a good chance you're in the Tazewell County jail. And so we realized that we had to get their data points as well and go back and forth. And so really, our data sharing in terms of our application, it's a 2-phase. We have our community level and investment. So how do we aggregate this and really phase it through? And then at what individual levels we can do in those type of interventions and change. I see that. Okay. So our next step really want to focus is getting that care coordination plan developed so that when people sign off on it, if I, Monica Hendrickson in that example, if I jump from the jail, Sheriff Asbell is not going to turn to me and say, oh yeah, you should stay here. They're going to have our care coordination plan and say, okay, have you been on your meds? How's your housing situation? Again, if they jump over into the emergency departments at one of our hospitals, one of them are going to say, okay, have you been at this location? What's your housing situation? They have a full 360 of that individual's entire scope, both their behavioral health and their medical health, as well as their social emotional health and their economic health. And so the sharing of this plan with law enforcement so that they meet you in the street, they're not necessarily jumping all the way into the ER or into courts, but really understanding how to assess you at that point in time properly. So that's the pie-in-the-sky dream that we're working towards. It is a work in progress, and right now you notice in that data point from the matrix, we actually only showed you everyone except for our hospital systems. And that's because that's still the challenge that we're facing right now, is how do we get our hospital systems on board? They all agree this is a great idea. The hard part is information sharing and at what point. And so our goal is to really look at where is the common denominator or the easiest win and start there to get that consent forms built and that relationship built before we kind of move towards the next steps. This is our contact information. We're doing questions now? Yeah, oh, okay. Any questions for us? Oh, at the end?
No, that's fine. Go ahead. If anybody has anything.
Can you talk, when you talked about the common care plan and inviting folks who are outside of the system into that, is that an electronic access or is it about sort of getting people at a table to do it?
That's
So the question was, what is the mechanism to enter the information in the coordinated care plan and how is the plan itself being developed? Great question. Right now, the form is paper. Of the matrix, I'll kind of go back. Okay, so as you can see, for example, person B, the Human Service Center is the one that had the most contact with that person. What we'd like to do is go back to them and say, person B is yours. Please approach them with this care plan, walk them through it, and have them sign off. Once they've signed off, then the Human Service Center can convene representatives from each of the different stakeholder agencies. And it's very comprehensive treatment-wise, but we also wanted to be sure, as Monica said, it encompasses the social determinants of that individual.
How much of the reason that it's paper is based on the cost of making it electronic, or is the bigger issue all of the legal restrictions on data sharing?
The question was, why is it paper and not electronic? I think it's several levels. Yeah. Number one, several of our people have access to Epic, but not everyone. And I think that's a goal, but right now, baby steps. If we can just get one paper care plan, I will be ecstatic. It will be wonderful.
Now, there are counties and communities that actually do this electronically, where there is call nodes for law enforcement, healthcare, homeless, and they do speak together. I know that would be, again, the dream in our community, but to build the financial leverage, so to speak, or the return on investment, so that we can see if we can get money from our community to actually fund that, is kind of where we're sitting right now.